So, good morning everyone. Today our topic of discussion is end-stage liver disease. Myself Dr. Debottom DNB critical care student. Last day we discussed about acute liver failure. Today our topic is end-stage liver disease, which is much more common entity that we find in our day-to-day clinical practice. So, end-stage liver disease is synonymous with decompensated chronic liver disease or advanced liver disease. So, the progressive deterioration of liver function for more than 6 months is known as chronic liver disease. So, it is a continuous process of inflammation, destruction and regeneration of liver parenchyma which leads to fibrosis and cirrhosis. So, now come about little acute on chronic liver disease and end-stage liver disease. Both actually presents clinical pictures quite similar, but in acute on chronic liver disease, actually what happens, often the compensated liver disease decompensate either by direct liver insult like ischemia or toxin like alcohol, and those with liver affected by a systemic inflammatory process like in sepsis. In acute on chronic liver disease, there is a possibility of improvement and reversibility if the patient do recover and they return again to the previous mortality trajectory. Now comes to etiology of chronic liver disease. The etiology of end-stage liver disease are same almost as chronic liver disease, all the other causes, like alcoholic liver disease is the most common cause. Histopathologically, centrilobular perivenular sinusoidal fibrosis are seen. Elevated level of AST more than ALT with a history of chronic alcohol intake usually there, and usually AST is to ALT ratio is 2:1 in alcoholic liver disease. Non-alcoholic fatty liver disease is associated with metabolic syndrome, dyslipidemia, diabetes and obesity, and some of these patients develop non-alcoholic steatohepatitis which ultimately leads to fibrosis of liver. Diagnosis mainly diagnosed by exclusion. Here ALT will be more than AST. Chronic viral hepatitis, another common cause of chronic liver disease. Chronic hepatitis B, C, D infection are more common. These cause a periportal fibrosis, septal fibrosis are characteristic in histopathology. Serology and PCR with genotype is needed for diagnosis. Genetic causes, there is alpha-1 antitrypsin deficiency, which is most common cause of genetic cause of CLD among children, and alpha-1 deficiency will be finding. Hereditary hemochromatosis and Wilson disease another two causes of genetic cause for chronic liver disease. In hereditary hemochromatosis, that is autosomal recessive disorder due to mutation involved in HFE gene. There is a pathological increase in total body iron, and the process leads to hydroxyl free radicals generation, and which causes the organ fibrosis. So, in diagnosis we have to check we will see the rise serum iron, ferritin, decreased total iron binding capacity, and liver biopsy will be confirmative. Genetic testing can detect a mutation in the HFE gene, especially C282Y. In Wilson disease, that also a autosomal recessive disorder, there is leads to copper accumulation. Earlier it was iron accumulation, here is the copper accumulation, rise urinary copper and decrease serum ceruloplasmin, that is the binding protein of copper, and the level will be decreased, and the liver biopsy are diagnostic. Genetic testing for ATP7B gene will be confirmatory. Autoimmune causes of chronic liver disease, this is mainly found in a middle-aged woman in autoimmune disease of liver. Primary biliary cirrhosis, which is destruction of the intrahepatic biliary channel and portal inflammation and scarring and fibrosis occur. It leads to cholestatic jaundice and fibrosis of liver parenchyma. Markedly raised alkaline phosphatase level with an antimicrobial antibody are diagnostic. Now comes to primary sclerosing cholangitis. It is most commonly associated with ulcerative colitis, and the condition is characterized by decrease in the size of intrahepatic and extrahepatic ducts due to inflammation and fibrosis. Autoimmune hepatitis is the form of chronic inflammatory hepatitis, as I told earlier, more common in women and characterized by elevated autoantibodies such as anti-nuclear antibodies, anti-smooth muscle antibodies and hypergammaglobulinemia. Miscellaneous causes, Drugs, amiodarone, isoniazid, phenytoin, nitrofurantoin, vascular like Buchieri syndrome, and idiopathic or cryptinitis around 15%. Now pathology, it is a general pathology, but every as per etiology the histopathology will difference, and there will be some difference in histopathology, but in generally there is a hepatic fibrosis, the liver tissue architecture destruction and regeneration nodule formation. Chronic liver injury activates hepatic stellate cell and which transform into a myofibrocyte like phenotype, and they then lay down extracellular matrix. Chronic inflammation, cytokine production by damaged parenchymal cell and destruction of the extracellular matrix are well characterized. Now clinical feature, sign and symptom of chronic liver disease can be non-specific, such as fatigue, anorexia, weight loss, and depends upon the complication the patient has developed. Actually in decompensated, when we utter the term decompensate, that means there is some complication already, there is development of the portal hypertension already is there. The three significant complications are because of portal hypertension, hepatocellular insufficiency and hepatocellular carcinoma. We will come one by one later. Come to portal hypertension. So in portal hypertension, there is a increased portal venous pressure more than 7 mm of mercury is considered as portal hypertension. But clinically, when the portal pressure is more than 12 mm of mercury, we will usually see the clinical features of portal hypertension. So practically, portal hypertension causes divided into prehepatic, hepatic and post-hepatic. But here we will discuss, as we will discuss in cirrhosis, we will mainly discuss on the hepatic cause of portal hypertension. So what happens, the cause behind portal hypertension, basically there is a increased portal resistance and hyperdynamic circulation that leads to portal hypertension. Now in why portal resistance increase by two factors, one is mechanical factor and another one is vascular factor. In mechanical factor, there is as there is fibrosis formation, regenerative nodule formation, and there is swelling of the hepatocyte cells. So there ultimately leads to increase the portal resistance. And in vascular factor, there is a hemodynamic change in hepatic circulation, that's like hepatic vasoconstriction and impaired response to the vasodilator stimulus. Apart from increased portal resistance, hyperdynamic circulation characterized by peripheral and splenic vasodilation, reduced mean arterial pressure and increased cardiac output also leads to portal hypertension. Splenic vasodilation causes increased inflow of systemic blood to the portal circulation, and that leads to portal hypertension. Now in long standing portal hypertension, ultimately it leads to some complication. There is as we all know, the portal vein is made up of superior mesenteric vein and splenic vein. So long standing portal hypertension will be there will be increase the splenic venous pressure, so ultimately lead to splenomegaly, which causes anemia, thrombocytopenia and leukopenia. So all these causes the increased chance of infection and bleeding disorder chance will be more. Not only that, in case of portal hypertension, there is a opening of the portosystemic circulation will be more, so there is a chance of formation of caput medusa, hemorrhoids and esophageal bleeding. And as there is in cirrhosis, there is a detoxification function of liver will be hampered, the anemia will directly go into the systemic circulation and to the brain, leads to hepatic encephalopathy. And long standing portal hypertension will increase the peritoneal capillary hydrostatic pressure, which leads to ascites. So these will be the long standing portal hypertension leads to all these complications. So treatment. The treatment is based on the pathophysiology. Either we have to decrease the portal blood flow or we have to decrease the hepatic venous resistance. So drugs that decrease the portal blood flow are mainly non-selective beta blocker like propranolol or somatostatin or its analog octreotide. These actually inhibiting release of glucagon and decrease the portal pressure. Vasopressin and terlipressin causes the splenic vasoconstriction and reduce the portal veins inflow and decrease the portal pressure. Drugs that decrease the intrahepatic resistance, these drugs are not commonly used, but this can theoretically cause the can use in portal hypertension, like combination beta and alpha blocker like carvedilol, alpha 1 blocker, angiotensin receptor blocking agent and nitrates. but these drugs are not that much effective, so not commonly used in routine practice. Long term sequelae, as I told earlier, ascites, protosystemic circulation, esophageal varices, hemorrhoid, caput medusa, hepatic encephalopathy, anemia, thrombocytopenia and leukopenia. Esophageal varices is the one of the most common, but our next topic of discussion is upper GI bleed, so I am not going to details into in esophageal varices. It is the most common and life-threatening condition of CLD, complication of CLD, which present with melena and hematemesis. Treatment mainly aggressive fluid resuscitation, vasopression and endoscopy. So endoscopic band ligation and injection sclerotherapy are the usual modality to treat variceal bleed in emergency. In some patients, early transjugular intrahepatic protosystemic shunt tips can increase the survival rate. Propranolol is the used for primary and secondary prophylaxis of esophageal varices. Now comes to ascites. So ascites, as we all know, accumulation fluid in the peritoneal cavity, that is caused by mainly three mechanisms: rise portal hydrostatic pressure, that is portal hypertension; decrease albumin, reduce oncotic pressure as liver function is not normal; and splanchnic vasodilation, so due to release of nitric oxide. Clinical finding in such patient are abdominal distension, shifting dullness, fluid wave, respiratory distress, early satiety. This can be clinical picture of ascitic patient. Grading: International Ascitic Club grades ascites into 3 grades: 1, 2 and 3. Mild ascites detectable only by ultrasound, grade 2 when moderate ascites detectable by physical examination, and grade 3 large ascites with tense and distended abdomen. Recurrent ascites, when there is a accumulation of ascitic fluid more than 3 times in a year, it is called recurrent ascites in spite of doing treatment. And there is early recurrence when more than 2 to 3 recurrence occur within 1 month, is called early recurrence of ascites. So this is the slide that shows the what is the cause of treatment, diagnostic purpose of a patient of ascites, not related to particularly cirrhosis, but the causes of ascites. We have to, any patient with ascites, we have to do this investigation like serum sodium potassium level. Urine sodium output is the very important responsive and good prognostic value if urinary sodium is more than 10 milliequivalent per liter. If it is more than 10, that is good for, the patient will be response to diuretics and its survival rate will be more. Urine protein quantification, standard blood test, liver function test, CBC, coagulation parameter, USG, and some cases liver biopsy. Diagnostic paracentesis is the investigation choice to see whether ascites are because of either portal pressure, high portal pressure, or another cause. So we have to check serum albumin, ascitic fluid albumin gradient, the SAR. If the gradient is more than 1.1, then the portal hypertension is the cause. If it is less than 1.1, then the cause may be nephrotic syndrome, pancreatic ascites, biliary ascites, serositis in connective tissue disease, etc. Apart from this, in ascitic fluid, we have to check the polymorphonuclear leukocyte, neutrophil count, total protein and albumin concentration. Bacterial culture and other tests depend on the clinical presentation like glucose, LDH, amylase, triglyceride, cholesterol, microbacterial culture, cytological examination, etc. Now treatment of ascites. Main treatment is diet, low sodium diet around 4 to 6 gram per day. In first episode of ascites, we have to give the diuretics, is the next choice of the pharmacotherapy of choice. Spironolactone 100 mg per day, increase in a stepwise manner every 72 hours according to treatment response to maximum dose of 400 mg per day. If no response or hyperkalemia develops, then we have to add furosemide 40 mg per day, increasing a stepwise manner to maximum 160 mg per day. So in case of recurrent ascites, we have to combination of diuretic treatment with spironolactone and furosemide. Daily body weight measurement also important. Once ascites has been mobilized, continue low sodium diet and minimum diuretic dose necessary to avoid reaccumulation. For tense ascites, therapeutic paracentesis is done and albumin infusion may be considered. Usually more than 4 liter paracentesis, there is an indication of albumin transfusion. Now comes to refractory ascites. Around 10% patient with end stage liver disease with ascites develop refractory ascites. Median survival approx 6 months. And what is the definition as diuretic resistant ascites and diuretic intractable ascites? In case of diuretic resistant ascites, up to the maximum limit dose of diuretic, there is still recurrence or accumulation of fluid. This is diuretic resistant. And diuretic intractable ascites means we can't give the diuretic because of its side effects. So you have to stop or withhold the ascites. So this is the definition of refractory ascites. The thing is that prior to declare the patient is a refractory ascites, we have to give at least 1 week of high dose, I mean 400 mg of spironolactone and 160 mg of furosemide as advised. Now treatment: large volume paracentesis with IV albumin. Diuretics to be continued only if urinary sodium more than 30 milliequivalent per day in order to delay ascites formation and delay interval between large volume paracentesis. TIPS, transjugular intrahepatic protosystemic shunting, associated with better symptom free days, but chance of hepatic encephalopathy are more and no survival bemetic. Alpha pump system that moves fluid from peritoneum to urinary bladder also gives symptomatic review. So we usually use the diuretic for the treatment of ascites, but we have to keep in mind the use of diuretic associated with AKI, hepatic encephalopathy, and electrolyte disbalance chances are more. Now come to spontaneous bacterial peritonitis, one of the most common cause of sepsis in CLD. Along with UTI and spontaneous bacterial peritonitis are the cause of most common cause of sepsis in CLD patient. Clinical presentation vary actually. So, can present with local symptoms such as abdominal pain, vomiting, diarrhea, or can present without symptom. Sign of systemic inflammation, fever, high leukocyte count, high CRP, tachycardia, deterioration of liver function, hepatic encephalopathy, AKI, septic shock, anything can be happen. But as the patient can present asymptomatic, therefore a diagnostic paracentesis should be done to look for SBP in all patients with cirrhosis with ascites on admission to the hospital. And whenever complication, particularly bleeding, hepatic encephalopathy, AKI develop, early diagnosis of SBP is important because of early treatment with antibiotic associated with good outcome. So pathogenesis is nothing but altered gut liver axis. So there is translocation of bacteria from systemic to peritoneal fluid and develop the SBP. Genetic factor may also contribute to the increased risk of infection in patient with cirrhosis. For example, patient with variants of NOD2 gene may have increased risk of SBP and a poor prognosis. SBP diagnosis: presence of WBC more than 500 per microliter or polymorphoneutrophil greater than 250 per microliter in ascitic fluid, and fluid culture will be positive in patients of SBP. E. coli, Klebsiella, Streptococcus pneumonia are the common organism. Now treatment depends on whether it is nosocomial or community acquired or healthcare acquired. In case of community acquired, third generation cephalosporin or piperacillin tazobactam are recommended. Healthcare associated without high prevalence of MDR organism, we can go for piperacillin tazobactam. In case of nosocomial or where the chance of prevalence of multi-drug resistance bacteria is there, then meropenem with or without vancomycin or daptomycin or linezolid can be used. But the thing is that SBP, after starting of SBP, we have to check the whether antibiotic is working or not. For that purpose, after 48 hours of starting of antibiotic, we have to redo the paracentesis and we have to check the value of presence of WBC count. If there is a less than decrease in the WBC is decreased more than 25% of previous count, then it is called that antibiotic is working, otherwise it is not responsive to the treatment. Now prophylaxis of SBP, there is a two, one is primary prophylaxis and secondary prophylaxis. Primary prophylaxis for patient with cirrhosis with ascites fluid, protein less than 1.5 gram per dl and Child-Pugh score more than 9, more than equal to 9, serum bilirubin level more than 3, creatinine level more than 1.2 and hyponatremia less than 130. Secondary prophylaxis, any patient with past history of SBP. Usually drug use, norfloxacin, ciprofloxacin or trimethoprim sulfamethoxazole. Now hepatic insufficiency. In hepatic insufficiency, hepatic encephalopathy is the common. Last day in acute liver failure actually discussed regarding hepatic encephalopathy. So I don't come details into the hepatic encephalopathy in this presentation. So almost 50% patient with decompensated chronic liver disease developed hepatic encephalopathy, which is a neuropsychiatric syndrome caused by hepatic dysfunction. The main function is the impaired detoxification of liver, and the harmful product of metabolism comes to the increased level of ammonia, not only ammonia but also short chain fatty acid, tryptophan metabolites. All these causes increased oxidative stress. Ammonia increase to the comes to the brain, and there is the accumulation inside the astrocyte. There is a cerebral edema and ultimately leads to hepatic encephalopathic features. So grading, grade 0, 1, 2, 3, 4, as we discussed already earlier. In grade 0 minimum, that is subclinical or normal mental status with minimal changes in the memory, coordination, intellectual formation and concentration. Grade 1 trivial lack of awareness, euphoria or anxiety, impairment of addition or subtraction, altered sleep rhythm, this can seen in grade 1. Grade 2 lethargy or apathy, disorientation to the time, personality changes, inappropriate behavior. Grade 3 somnolence to semi-stupor, responsiveness to stimuli, confusedness, disorientation, and grade 4 is the coma. So basic principle of the treatment is precipitating factor, mainly we know the infection, we have to treat the infection. Along with that, we have to treat with rifaximin and lactulose. Those lactulose help by converting ammonia to ammonium ions and decrease the absorption from the GI tract. But as we know earlier class, both rifaximin and ammonia is not recommended by recent study of European guideline. Jaundice is another symptom of chronic liver disease, which is yellowish discoloration of the eye, skin and the mucous membrane because of the overproduction or under clearance of the bilirubin. Metabolism of hemoglobin or myoglobin produce bilirubin, which circulates with body along with bound to albumin. So hepatic endoplasmic reticulum converts this unconjugated bilirubin to conjugate bilirubin by glucuronidation. So jaundice is the clinically visible when total bilirubin is more than 2 mg per dl. As in chronic liver disease, there is a destruction of the liver parenchyma and it does not able to conjugate the bilirubin which deposit in the various tissue and of the body. Now come to cirrhotic cardiomyopathy. Impairment of systolic and diastolic function occurs in cirrhosis. Impairment of beta adrenergic signaling pathway that lead to subnormal chronotrophic and contractile response, as well as the cardiomyocyte dysfunction resulting from overproduction of nitrous oxide, carbon monoxide and endocannabinoids. Prolongation of the corrected QTc also have been observed in patient with cirrhotic cardiomyopathy. Treatment mainly symptomatic, diuretic and other supportive. Endocrine abnormality in form of adrenal insufficiency, thyroid dysfunction and osteoporosis. Now in chronic liver disease, there is a catabolism of estrogen become impaired, resulting excess estrogen in the body. This leads to palmar arrhythmia, spider nevi, gynecomastia, testicular atrophy. Coagulopathy, as we know, there is a splenomegaly and liver function, both are hampered. So there is a low platelet count, altered PT, INR, APTT, both intrinsic and extrinsic pathway may be prolonged, chances of bleeding may be present. Now comes to hepatorenal syndrome. Hepatorenal syndrome is a functional renal failure as kidneys are normal, but there is a gradual loss of renal function. Hepatorenal syndrome is a diagnosis of exclusion. The incidence of HRS in decompensated liver disease around about 4%, and probability of developing HRS at 1 year is 18% and at 5 years is 39% in patient with DCLD. The main mechanism of pathophysiology of hepatorenal syndrome is the renal vasoconstriction and reduce of GFR, mainly activated of the RAS activation and plasma ADH secretion. So, which ultimately leads to renal vasoconstriction, decreased renal perfusion, and ultimately hepatorenal syndrome. So, diagnostic criteria for hepatorenal syndrome: number 1, cirrhosis with ascites. Number 2, there will be AKI as defined, 50% increase in the serum creatinine level from baseline that is known or presumed to have occurred within 7 days prior, or a rise of 0.3 mg per dl in the serum creatinine level within 48 hours. There is a no or insufficient response in 48 hours after diuretic withdrawal and adequate volume expansion with IV albumin. Absence of shock, no evidence of recent use of nephrotoxic agent, and absence of intrinsic renal disease as indicated by proteinuria of more than 500 mg per day, microhematuria or abnormal renal ultrasound. So, it has two types, as we all know, type 1 and type 2. Type 1 is more severe and more acute, whereas type 2 is less severe, slow onset, and usually diuretic resistance. Now, prevention of HRS, avoidance of intravascular volume depletion, judicious management of nephrotoxin, and prompt diagnosis and treatment of infection, and SBP prophylaxis is the treatment for HRS. Now, prevention. Now, treatment: discontinuation of all nephro and toxic agents, antibiotic for infection, IV albumin, bolus 1 gram per kg per day on presentation, continue at dose of 20 to 60 gram daily as required to maintain central venous pressure between 10 to 15 cm of H2O. Vasopressor therapy in addition to albumin is recommended, like terlipressin. Start with 1 mg IV every 4 hourly, then increase up to 2 mg IV every 4 hourly if baseline serum creatinine level does not improve by 25% at day 3 of therapy. Apart from terlipressin, we can use midodrine and octreotide. Midodrine 2.5 to 5 mg orally 3 times daily, increase up to maximum 50 mg 3 times daily, whereas octreotide we start with 25 mg IV bolus and continuous infusion 25 mg per hour, or subcutaneous 100 mg 3 times daily, increase up to 200 mg subcutaneously 3 times daily. Or norepinephrine we can use 0.1 to 0.7 mg per kg per minute IV infusion and increase by 0.05 mg per kg per minute every 4 hourly, tighter accordingly. The duration of vasopressin support is generally maximum 2 weeks until the HRS is reversed or liver transplantation is performed. So, patient, as well as we have to, as the treatment is liver transplantation, we have to evaluate the patient for liver transplantation possible or not. Now, thing is that a pooled of analysis, 2 large randomized study showed that terlipressin plus albumin was superior to albumin alone in the frequency in which HRS reverts. The patient with type 2 HRS with terlipressin and albumin does not have beneficial effect on either pre and post transplantation. So, albumin and terlipressin is better, particularly in type 1 HRS. If we compare between albumin with terlipressin and albumin with midodrine and octreotide, it is studies shown that the terlipressin group is better. Similarly, norepinephrine group 2. Radiological and surgical therapy for HRS is TIPS, intrahepatic portosystemic shunt, is effective for treatment of diuretic resistance ascites, a precursor of type 2 HRS. But liver transplantation is the only therapeutic modality that has potential to reverse both the liver function and HRS. So, it should be considered in every case. Rate of post-operative complication and in-hospital mortality rate are higher in patient with transplanted with HRS patient when we compare with transplant without HRS patient. Hepatopulmonary syndrome. Hepatopulmonary syndrome is characterized by hypoxemia due to microvascular alternation and dilatation of the precapillary and capillary pulmonary arterial circulation in presence of cirrhosis with portal hypertension. So, diagnosis made by mainly there is a dilatation that causes the hypoxemia. The partial pressure of oxygen when less than 80 in room air. A scoring system, but two are more commonly used. One is Child-Pugh score, which uses ascites, bilirubin, albumin, PT and encephalopathy. So it has three parameters, 1, 2, 3 according to each value actually. Like bilirubin more than 2, more than 3.5, 2.2 to 3.5, less than 2.5. Similarly, everything has 1, 2 and 3 point and these 5 parameters. So class A when score 5 to 6, that is well compensated disease. Class B 7 to 9, functional compromise, and class C score 10 to 15, decompensated liver disease. Now prognosis analysis model of end stage liver disease score. It includes bilirubin, creatinine, INR. So it has value ranges from 6 to 40. Higher the score, the higher the chance of 3 months mortality related to the liver disease. MEL score is practically for implication for liver transplant, for predict the mortality after liver transplant or TIPS. So prognosis, overall decompensated liver disease, patient have poor prognosis, mean survival about 6 months if Child-Pugh score is more than 12 or more, or MEL score is more than 21 or higher. That's all. Nowadays actually palliative care regarding end stage liver disease, there is a multiple studies going on, and multimodality approach also implicated.
See, it was an exhaustive discussion. But the commonest thing you see in clinical practice is spontaneous activity. In addition to antibiotics, what we have not mentioned is clinical trials have shown that you should use albumin. In addition to giving antibiotics, during the acute phase, in the first 3 days, you have to add albumin. It has been shown that if you do the combination of antibiotic and albumin, the mortality decreases. That is important. So you have to give albumin to diagnose somebody that is regarding prophylaxis. এটা তুমি বললে primary prophylaxis we rarely use nowadays. Secondary prophylaxis now is controversial. যে তুমি criteria গুলো বললে, সেই criteria গুলো are accepted, but the problem is antibiotic resistance. Because we have to do it lifelong. If you start, if you think of it, we are trying to prevent a second disease, so you have to do it lifelong. আমাদের দেশে especially problem of antibiotic resistance. সেজন্য আমরা ইউজ করি না, sometimes ইউজ করে limited time. নম্বর হচ্ছে যে তোমার নেক্সট ইজ হেপাটিক এনকেফালোপ্যাথি, যেটা তুমি বললে ট্রিটমেন্টটা কি বললে আমি বুঝতে পারবো।
Actually sir,
যেটা বললে
ল্যাকটিউলোজ এন্ড রিসাক্সিমিন যেটা বলা হয়েছে ইউজ করা হয়।
ল্যাকটিউলোজ, when will you use ল্যাকটিউলোজ and rifaximin, and when you use both? যেটা দেখা গেছে যে somebody has a recurrent hepatic, there are more than one, then using a combination is that. The first episode যাদের হচ্ছে একবারই হচ্ছে just need ল্যাকটিউলোজ। Clinical trials have shown a combination.
That in hepatic encephalopathy, the precipitating factors like infection, constipation, dehydration. So we have to make sure that the patient doesn't go into diarrhea outside that course. But dehydration further aggravate hepatic encephalopathy.
সেটা তোমাকে যেটা hepatic encephalopathy, especially you have to look for a cause. Mostly যেটা বলি, one of the commonest cause you see is constipation. You have to ask for constipation, you have to, if there are diuretics, you have to look for electrolyte imbalance, etc. Sepsis can precipitate. So, treatment also. Number HRS বলতে, HRS is the most dire complication of cirrhosis, end-stage. HRS is type 1 and type 2. If you look at it, conceptually, type 2 is a continuation of the deterioration in liver. Type 1 is something which has happened on top of somebody who has got a bad liver. Even type 1A prognosis is worse. Early pressing albumin combination has been found to be useful in type 1. Type 2 is just like the liver disease is progressing, it is getting worse and worse. So type 2 is the only thing which helps is really transplantation. And nothing else helps in type 2. But type 1A you can, patient can recover, but ultimately its prognosis is poor. Because it ultimately will go back to end stage liver disease, advanced end stage liver disease. তো এটা করতে হবে আর একটা হচ্ছে যে you haven't mentioned hepatic hydrothorax. It is a rare complication, but
yes, actually,
what everybody should know is in hepatic hydrothorax, which is really effusion on one side, usually on the right side, but can be left, can be bilateral. You should never put a drain, just drain.
liver transplant is the choice treatment.
You can try something like a TIPS. If their med score is less than 12, 13, it's a liver function good, but you should never put a chest drain. If you put a chest drain, you will never be able to take it out. It has been shown in clinical trials that using a chest drain in somebody who has got a hepatic hydrothorax, the outcome is poor, survival is less, infection complications, all the time. যেটা বললে যেটা portopulmonary or hepatopulmonary syndrome, usually it is reversible. If you do a transplant, then everything in the lung will recover. The only thing you have to see is before doing a transplant to somebody who has got hepatopulmonary syndrome, if the pulmonary artery pressure is low. If the pulmonary artery pressure is high, then you have to think twice before doing a transplant.
What are the clinical signs and symptoms of hepatopulmonary syndrome?
People usually come, they have ascites, or they may not have a large ascites, but they are short of breath. And you do a chest X-ray or something, you see a large diffusion on one side. You isolate the diffusion and see whether it matches the biochemical profile matches that of ascites. So protein might be slightly higher. And if it matches and you can't find any other cause, you do a CT most of the time. Just look if the creatinine is alright. You have to look at the creatinine. If the creatinine is alright, you do a CT. And if there is nothing else, then you diagnose it as a hepatic hydrothorax. Clinically, it's not a breath failure.
Hypoxemia. Ortho.
Sitting down, which gets relieved after line of position. And what is that microagitated echo, microagitated saline echocardiography? What do you do in there and what we see? আসলে মেশিন কিন্তু আমার কি করে
ওটা লেখা ছিল
This what we do is a microagitated saline of almost diameter of 50 micrometer is pushed through peripheral vein. Thereafter, we do an echocardiography. We look for right atrial opacification, and then the duration after which we see left atrial opacification through that agitated saline. If the duration is roughly around 8 to 10 cardiac cycles, then it is due to hepatopulmonary syndrome. And suppose it occurs between 3 to 4 cycles, then the cause might be cardiac shunt. Cardiac shunt. And what sir told, what are the diagnostic criteria for, not diagnostic criteria for liver transplant in patients with hepatic pulmonary syndrome?
Pulmonary arterial pressure must be
should be
less than 18.
The mean pulmonary arterial pressure should be less than
35.
And more than 45 is a contraindication for liver transplant. Between 35 to 45, you need to give some medical therapy. If it improves, well and good. If it doesn't improve, then you have to look for pulmonary vascular resistance, which should be at less than 240. If mean arterial pressure is above 35 but below 45, with this pulmonary vascular resistance of below 250, then we can opt for liver transplant. And what is this MAS scan? Technetium 90 album MAS scan. This is radioactive blood perfusion scanning. what is the pathophysiology? There is recapillary dilatation.
Dilatation.
So whenever we give this albumin, ideally should not cross the lung, but it crosses the lung, which is other systemic circulation like brain or liver, lung or brain, kidney, anywhere. Then that means there is a precapillary dilatation, which is diagnostic for this hypertension. So showing brain shunt fraction of more than 6%.
Initially you mentioned about the etiologies, na? So ওখানে তুমি primary kidney specification. তো স্যার এখন তো নামটা চেঞ্জ হয়ে গেছে। You mentioned primary kidney cholangitis. Primary kidney
cholangitis.
And the second thing, স্যার তো জিজ্ঞেস করবো যে এখানে তুমি ascites treatment-এ you said about sodium restriction. তো মানে তুমি 4 to 6 gram per day দিয়েছো। তো I would like to ask স্যার, আমার মনে হয় স্যার একটু বেশি রাখতে একটু কম হবে, মানে 4 to 6 I think is more.
The problem with the direct connection mentioned colony which is becoming increasingly important sarcopenia. Okay. Patient has a cirrhosis.
Liver muscle uptake of
Sarcopenia, muscle loss. So the problem with restricting sodium too hard is the intake increases, the protein intake becomes inadequate and they develop sarcopenia. So you have to carefully balance it. You অনেক সময় কি হয়, we restrict it very severely and the patient stops it, which is even worse. So you have to be careful about restriction. Ideally যেটা বলে যে 2 grams, 4 grams, but practically it is not possible in আমাদের যে diet. It becomes extremely difficult because if you do that very strictly, they stop eating. And if they stop eating, the sarcopenia increases. And sarcopenia has been directly correlated to the mortality. যাদের sarcopenia বেশি হয় তাদের mortality liver disease বেশি আছে। So you have to be careful about that. You should not restrict protein in them. This is another thing. But on the tendency actually, if somebody has got a cirrhosis, we tend to restrict protein. But we should not really restrict protein. We should have high protein diet. We should have at least 60 to 80 grams of protein.
One more question, sir. যখন generally full overload ascites edema patient আছে, so generally doctors tend to advise to restriction also breathing to this area. So should that be routinely advised?
But usually it has been shown that it doesn't help much. But they should not take a lot of fluid, but you should not restrict it to fasting.
And my last question, sir, you mentioned about the treatment of diabetes that we should start with spironolactone and then if the patient doesn't respond, then we have to add furosemide. But is it the other way around that we can routinely start with a fixed ratio of furosemide and spironolactone from the beginning, which is better? And sir would be
This is the classical teaching. What he has shown is the classical teaching, but usually what happens is by the time they come to us, they have developed a degree of ascites, and bhalo ascites, that's why we tend to start with a combination. Spironolactone khali use korle large dose the problem
potassium.
If you use a combination, the chances of developing hyperkalemia is less.
Yes.
So if somebody has got a mild ascites clinically, then I tend to start with spironolactone only. But if they have a moderate ascites, then I use a combination. And the problem is here you see that the recommendation to the patient, you can't see them after 3 days, you can't see them after 7 days. Usually they come after a few weeks. So you have to be judicious in that.
Debottom, how do you define this no response to spironolactone? How do you define no response to spironolactone?
So define.
Yeah.
So slowly Debottom go to the maximum dose of 400 milligrams per day.
What do you mean no response to spironolactone? No response or
Body weight, reduction of the body weight.
body weight of
0.5.
that is response. No response is if body weight reduction of less than 2 kg per week in non-edematous patient and less than 3 kg per week in edematous patient.
You have done a
wonderful class, huge, it's exhaustive thing. Just try next time. Try to give references. Try to speak more on trials. Put more tables, diagrams. Right? It seems like more of an ambiguous undergraduate study. Now you are beyond that. Right. One question: why was terlipressin not given FDA approval?
At the
Between terlipressin and noradrenaline, if you are giving for HRS, which one will you choose? Because terlipressin is not FDA approved, right? So why was not that approved, and which one should we choose?
terlipressin associated with mortality chance is more with terlipressin, and the risk of cardiac compromise, I mean arrhythmia, is more with terlipressin,
As compared to
not norepinephrine,
Norepinephrine.
most probably.
so which one will you choose? Terlipressin or noradrenaline to treat HRS?
Which one is better, he's asking.
For treatment, HRS recovery, terlipressin is better. But as the mortality is increased with terlipressin, we use norepinephrine usually.
Uniform is good. He's asking if there is a patient in ICU or actually the patient has a uniform type. Which one will you use?
Terlipressin with albumin.
You just said terlipressin. This is mortality. So
But recovery and reversal of HRS is more better with terlipressin.
You see, under standard data, but the problem is data pool. FDA has not approved 30%. They are doing a randomized trial in US now, which has not been published. So they are hoping they will get a license soon for 30%. Into normally it has been shown, people have compared 30% and albumin compared versus noradrenaline in Europe. And it has been found that 30% and albumin is better than noradrenaline. So you should, if available, you should use 30% and albumin. But the problem is 30% is very expensive. You have to 1 milligram photogram. Any idea? It is 1400 rupees.
for
5,000.
noradrenaline, you will have to put patients on cardiac monitor. Usually it will require ICU. Terlipressin you can give in ward. So that is why usually we tend to incline toward terlipressin, even though it doesn't have a FDA approval and it has a complication that the statin comes with it. So this is one thing. Few more things. This low sodium diet, 4 to 6 gram in Indian healthy male will not be restricted. This is the usual sodium diet. So you need to bring it down to 3 gram per day. But balance it with the malnutrition, as sir explained, sarcopenia concepts. And along with ascites, when you are teaching ascites, because although it's a very big thing, if you keep talking for 1 month, it will keep going on. Such a huge topic we have covered wonderfully in just a matter of 1 hour. Just explain what are the differential diagnoses, the students, because students are here, what are the differential diagnoses they will see with the ascites. What is like, when you are from emergency, this is emergency class, what is abdominal compartment syndrome and all, you need to just put it all. And references will be good, some few trials, backing statements.
I think it's a huge topic. So itself, one is in portal hypertension itself is one chapter. HRS itself is one chapter.
Measuring portal hypertension.
Yeah, I did
measuring
not.
one thing, bench pressure is not sufficient.
Exactly.
Measuring portal hypertension will
Splenic
require
pulse pressure, hepatic venous pressure, differences with which kind of cause of portal hypertension. It's a huge thing.
And for everything, ultimate diagnosis is basically tissue diagnosis. Ultimately, you have to have a biopsy.
Arrectal disease lack of Ashtar, but the concept of cirrhosis is slowly changing. In the sense, we nowadays think it is a pro-inflammatory process because of translocation from the gut. So it is just not a passive fibrosis process. There is an active inflammation going on in the body in addition to the So people have tried antibiotics, whether to see it helps in reducing the progress of cirrhosis or it reverses of cirrhosis. The USAID large-scale trial shows they are using rifaximin in small dose, slow-acting or long-acting rifaximin in slow, 50 milligram of Hanayactam. So they are doing a clinical trial. see whether it really retards the progress of cirrhosis. But the problem is, in order to see that, it has to be a very long drawn trial. Now it's Bodam Kubushi. So they're doing a trial. So the concept of cirrhosis is slowly evolving, changing. It is not just a passive process. And especially in hepatitis, viral hepatitis B and C, it has been shown that if they are in early stage of cirrhosis, and if you treat them effectively with antivirals, there is a regression of cirrhosis.
In fact, Harrison says alcoholic liver cirrhosis is reversible cirrhosis.
It can't be reversible. I have seen patients who have been put on liver transplant list, alcoholics. They have stopped drinking, and some of them have come out of transplant list because their liver function has improved so much. It is possible, but now it is very difficult.
What is the role of albumin dialysis? Particularly development.
These are
Osmotic gradient.
Does it have any benefit? It is usually used as a bridge treatment till liver transplantation. Doesn't mean mortality benefit. It's just a bridge therapy.
If you are waiting for a liver to come and you want the patient to
You buy more days.
it tends to decrease the bilirubin and improve a bit of insulin.